Hello, my dear champs. Hope you're good and preparing well for your upcoming MRCOG exam. Introducing myself, I'm Dr. Dinesh, one of the mentor of Team Study Medics, and here I welcome you on the KickStart series of MRCOG Part 1. The topic for discussion is adrenal disorders, a very important topic in endocrinology, which is very commonly asked in your exam. Let's start the sessions with a beautiful quote: strive not to be a success, but rather to be of value. And the value you get with a very important title of MRCOG. Let's talk about the adrenal hormones. Before that, we will understand about the adrenal glands in detail. We know that the location of the gland is above the kidney. The adrenal gland is divided into the cortex and medulla. Medulla is containing the chromaffin cell. Medulla forms from the neural crest cells, that is the modified neural crest cells. The cells from the medulla secretes the catecholamine, which includes the dopamine, adrenaline, and noradrenaline. And the action of this is about the lipolysis, the glycogenolysis, the salt and water balance in our body. It do relaxes the GIT, that is gastrointestinal tract smooth muscles, and also induces the secretion of insulin. A very important, the cascade of enzyme that start with tyrosinase, which converts the L-dopa into the dopamine, which get converted into a noradrenaline, into the final product, that is adrenaline, which is very important in our body. Talking about the action of adrenaline, noradrenaline, adrenaline acts on alpha and beta receptor. Noradrenaline acts only on alpha receptor. In a fetus, there is a dominance of L-dopa. Let's discuss about the part of the adrenal gland which include the cortex. There are the diagrams which shows about the transverse section and the microscopic section. As we know that the inner portion, which is the medulla, which contains the chromaffin cell which secretes the catecholamine. The outer portion is called as cortex. The cortex in microscopic section, if you could see, it is divided into a three very important zones. The outer is called as zona glomeralis, which followed by a zona fasciculata, and the inner one, the innermost, is called as zona reticularis. The zona glomeralis secretes the mineralocorticoid, zona fasciculata secretes the glucocorticoids, and zona reticularis the secretes DHEAS, DHEA, and androstenedione. These are nothing but the androgens. The full form of DHEAS is dihydroepiandrosterone sulfate, which is very specific to the adrenal gland. And all these three important constituents comes from the precursor called cholesterol. Let's discuss in detail about these adrenal gland hormones. Zona glomerulata secretes the hormones mineralocorticoid. Example is aldosterone. Its secretion is regulated and stimulated by angiotensin II. What are the functions of mineralocorticoids? It regulates the salt and water balance in our body by increasing the sodium and water absorption and the potassium secretion by the distal convoluted tubules in the kidney. Talking about zona fasciculata, which secretes the hormone glucocorticoid, the examples are cortisol and the weak androgens. It is stimulated by the adrenocorticotropic hormone, that is ACTH, which is secreted from the pituitary. The function is to suppress the immune response and regulate the carbohydrate metabolism. Adrenal cortex again secretes a very important hormone, that is weak androgen, from the zona reticularis, and this weak androgen includes the dihydroepiandrosterone. Its stimulation is by ACTH, that is adrenocorticotropic hormone, and the function is that it acts as the precursor for testosterone production in our body. As we have already discussed about the adrenal medulla, which contains the chromaffin cells which secretes the catecholamine, its secretion is regulated by a preganglionic sympathetic neurons. What is the function? The function is increasing the heart rate, the respiration, the blood pressure. Also, it causes the constriction of the vessels so as to decrease the blood flow to the GI tract. Moving ahead, let's discuss in detail about glucocorticoid. It includes the cortisol and the corticosterone. The function, it includes it in all system of a body. For example, metabolism, it increases the gluconeogenesis and lipolysis. It decreases the peripheral uptake of glucose. In protein, it inhibits the protein synthesis except in liver. During the inflammation, it decreases the response. In bone, it decreases the bone formation and that how it favors the osteoporosis. In terms of electrolyte balance, it increases the glomerular filtration rate, it increases the phosphate secretion, and also it increases the sodium and water retention in our body. In gastric, in GI, it increases the gastric acid secretion. Talking about memory, it helps in creating the beautiful memories, and in pregnancy, it helps in the lung maturation of the fetus. Talking about mineralocorticoid, which include the aldosterone, which is a very important part of renin-angiotensin system. And what's the function of this aldosterone is it acts on the posterior pituitary to release the antidiuretic hormone. It also causes the reabsorption of sodium, water from the distal convoluted tubules and the collecting ducts of the kidney. It also causes the excretion of the potassium and the hydrogen from the kidney. Its secretion is under the regulation of the renin-angiotensin system, juxtaglomerular apparatus, sympathetic nervous system, and also the serum concentration of the sodium and potassium. Let's talk about this adrenal glands in detail. There are certain physiological changes which are associated with the pregnancy. There is increased circulating cortisol level, which is 2 to 3-fold higher at terms than in non-pregnant women. Estrogen induced increased corticosteroid binding globulin increases the cortisol half-life secondary to the decrease in the hepatic clearance. And talking about the placental production of cortisol releasing hormone, which induces the adrenal hypertrophy and enhances its responsiveness to the synthetic ACTH administration during the course of pregnancy. And that's how it makes the ACTH stimulation test or synthin test to be insignificant during the course of pregnancy in an order to diagnose the adrenal pathology. So here is the diagrammatic representation where you could see that the peak is at 26 weeks and there is a diurnal variation is maintained for the total and the free cortisol level as they are increased. ACTH directly acts on the adrenal gland and you could see that there is a placental increase in the secretion of ACTH and CRH in the course of the pregnancy. Estrogen stimulates the cortisol binding globulin and which in turn causes the increase in the adrenal cortisol secretion. So let's talk about the pathological disorders that arises from the adrenal gland. The first is the primary adrenocortical insufficiency, very popularly known as Addison's disease. Second is Cushing syndrome, primary aldosteronism, congenital adrenal hyperplasia, very important in terms of MRCOG part 1 and part 2 syllabus, Pheochromocytoma and the paraganglioma. Paraganglioma is very less likely to be asked in an exam, but yes, congenital adrenal hyperplasia always gets the weightage along with that pheochromocytoma, and in part 1 they do ask more commonly about Addison's and the Cushing disease. Let's talk about the Addison's disease. There is a decreased production of the ACTH and that results in the primary adrenocortical insufficiency. How it clinically manifests? It manifests by means of hypertension, hyponatremia, hypoglycemia, hyperkalemia, and hyperpigmentation. Etiology could be a congenital adrenal hyperplasia. It could be an infection in the form of TB and CMV, that is cytomegalovirus. It could be because of the autoimmune causes, or it could be because of amyloidosis. Amyloid is nothing but a proteinaceous substance which gets deposited into the body. Adrenal hemorrhages could be one of the very important cause, and there are certain drugs which can provoke the Addison's disease that include the ketoconazole or rapid withdrawal of the exogenous drug, and the treatment is to supplement with the help of steroids. This is a diagrammatic presentation of the Addison's disease where you could see that the very pronounced features, that is the bronze pigmentation of the skin, change in the distribution of the body hair patterns. These patients do have the GI disturbances and the weakness. They do get the episodes of the hypoglycemia, posterior hypertension, and weight loss too. In adrenal crisis, you can find a profound fatigueness, dehydration, and vascular collapse by means of hypertension and renal shutdown, which causes the decrease in the sodium level in our body and increasing potassium level. Talking about primary adrenal insufficiency in Addison's disease, which is categorized into primary, secondary, and tertiary. Primary is nothing but an adrenocortical disease. It results from both glucocorticoid and mineralocorticoid deficiencies. It also because of the autoimmune atrophy of the adrenal gland, and which accounts about 70 to 90% of the primary adrenal insufficiency. Talking about secondary adrenal insufficiency, it is because of the adrenocorticotropic hormone, and it results mainly from the cortisol deficiency. Lastly, the tertiary adrenal insufficiency. In that context, it is because of the corticotropin releasing hormone related disorders, and it also results from the cortisol deficiencies. There are very, very important tests in terms of diagnosis of the adrenal disorders. Let's have a quick review about this test. The first is morning cortisol level or 9 a.m. cortisol level, or its insufficiency of cortisol at the morning. The level is always at the peak in a normal patient. For diagnosing the adrenal insufficiency, if the value is less than 100, it is suggestive of adrenal insufficiency. If it is more than 400, it is very less likely, but between 100 to 400, you need to confirm by means of synaptin test. Talking about synaptin test, it includes the utilization of the synthetic ACTH. It measures the cortisol before and after the injections. And if the adrenal function is well, the cortisol increases after the injections. There is called a short test. The sample is taken after 30 minutes. In long test, the sample is collected over a duration of 24 hours. And how much ACTH will be injected inside the body is 250 microgram of the drug. This test is very, very important in terms of diagnosis. There is also another test called as low dose DEXA separation test, very importantly done in the Cushing syndromes, where 1 milligram of DEXA is given at 10 p.m. and 9 a.m. the baseline sample is taken and the first tablet at 9 a.m. For next 48 hours, the 0.5 DEXA is taken orally, and day 3, the 9 a.m. blood is collected for the cortisol level. And the normal response is that the cortisol level is less than 50 nanomole per liter. Talking about the high dose DEXA separation test, where in low dose we are using 1 milligram, in high dose we are using 2 milligram. It differentiates between the ACTH dependent or ACTH independent tumors for the diagnosis of adrenal pathology. Going ahead, in Addison's cases, in non-pregnant patient, the diagnosis is high likely by means of 3 ways. The first, the morning cortisol level, the second is by short synaptin test, and lastly the salivary free cortisol level. Morning cortisol level less than 140, this is what mentioned in the TOG article, in combination with the elevated plasma ACTH concentration, which is more than twofold above the upper limit of the reference interval, that can help you in diagnosis of the Addison's disease. A short synaptin test, stimulation test, unless the basal results are unequal, the test involves the IV or intramuscular administration of 250 microgram of synthetic ACTH, preferably in the mornings. A normal rise in serum cortisol concentration after either 30 or 60 minutes, which is more than or equal to 500 to 550 nanomole per liter. This cutoff value is, however, unreliable in pregnancy, but it excludes the primary and secondary Addison's adrenal insufficiency. Talking about salivary free cortisol, it may be consistent and generalizable and physiologically rational measure of adrenal function in pregnancy rather than the total cortisol level. So it can be considered. So how to manage the primary adrenal insufficiency? It is same like as we do in non-pregnant patient. Here we need to do a supplementation with the help of hydrocortisone, which is a preferred glucocorticoid because it is short acting and does not cross the placenta. Prednisolone could be used for the glucocorticoid replacement in a patient with a poor compliance, and there is an overlap between the symptoms of adrenal insufficiency in pregnancy, including the postural hypertension and fatigueness, and that's the reason during the course of pregnancy the diagnosis of this condition becomes difficult. Let's talk about acute adrenal insufficiency or Addison's crisis. It is a rare and very importantly, it is a life-threatening emergency. The symptoms is abdominal pain, vomiting, shock, that is hypotension you can see over there. Adrenal crisis may occur in a patient with primary or secondary adrenal insufficiency. especially in the setting of severe hyperemesis with a decreased absorption of medication and sudden withdrawal of their therapeutic doses. Recovery is typically quick, usually within a 24 hour of commencing the treatment. Hydrocortisone and prednisolone are excreted in the breast milk in a very low amount that unlikely to harm the baby, so it can be safely utilized. Very importantly, there is 6-day rule have been developed to reduce the risk of acute adrenal insufficiency. So what is the 6-day rule? The 6-day rule is that always wear the medical alert or the bracelets or necklace so that people will come to know that this can be a adrenal insufficiency episode. Double the dose of oral glucocorticoid in cases of fever and illness and requiring the bed rest because the stress is where the deficiency of steroid can happen in the body. Provide intramuscular hydrocortisone for a self-administration in cases of the gastroenteritis or during the fasting too. So management of the glucocorticoid and mineralocorticoid during the delivery and the post-delivery, how it is to be done? First, on day 1, day of delivery, give the 200 milligram per day of hydrocortisone in divided dose intravenously or orally and hold the fludrocortisone. The second step is that on day 1 of postnatal, give 100 milligram per day of hydrocortisone in divided dose. Either it can give in orally or intravenously. Till that time, we can have the hold on fludrocortisone. On day 3, the third step, on day 2 of the postnatal, give the 50 milligram per day. So you can see that it starts from 200, 100, 50. So it goes in a tapering fashion. And that's how we need to remember that steroid should not be abruptly stopped. It has to be stopped in a tapering fashion. At the time of discharge, the hydrocortisone is given in the dose of 30 to 35 milligram per day. And that point of the time, you can start with the fludrocortisone. And during the follow-up, you need to arrange at the follow-up at the endocrine clinic. The dose of hydrocortisone could be brought down to the pre-pregnancy level so that she can cope up with the condition. And also in that context, you need to encourage your patient for the breastfeeding. Let's moving ahead with a very important topic, that is Cushing syndrome. What could be the etiology? The adrenal adenoma accounts for 60% cases in pregnancy. It not causes the excess of androgen secretion and hence are less likely to cause the menstrual irregularities. There is something pituitary dependent Cushing syndrome which accounts for 70% of those outside the pregnancy. On the other hand, the adrenal hyperplasia and some adrenal carcinoma produces large amount of androgen and spontaneous pregnancy is very unlikely in this group of patients. So what exactly happened that there is excessiveness of glucocorticoids and clinical feature manifesting in terms of hypertension, hyperglycemia, hyperlipidemia, hypokalemia, osteoporosis, amenorrhea, and obesity. So you could see that this is quite opposite to the Addison's disease. What could be the causes? The small cell carcinoma of the lung, the carcinoma of pancreas, the carcinoids, the pheochromocytoma, and there are the ACTH dependent and ACTH independent condition. When it is ACTH dependent condition, it will be considered as Cushing disease. Also, ACTH dependent condition could be because of the ectopic ACTH production. ACTH independent, it's by means of iatrogenic or adrenal neoplasia, and the management is that whatever is the cause, whether it is small cell carcinoma of lung or any pathology like carcinoma or pheochromocytoma, in that context you have to treat the cause. So this is a diagrammatic representation of the Cushing syndrome where you could see that there are the red cheeks, the fat pad that is like buffalo hump, abdominal stretch marks, you could see that the pink color stretch mark. There are the easy bruising or the dependent or the pressure points of the body. The abdominal is very pendulous. And there are the thin arms and the legs that can be seen. So it's like a lemon on stick appearance. There is a very important definition, that is pregnancy associated Cushing syndrome. It is defined as the onset or occurring during the gestation or within the 12 months of delivery or miscarriages. And this may result from the nodular hyperplasia of adrenal stimulated by the post-placentally produced ACTH or stimulation of the ACTH receptor in a pre-existing but undiagnosed adrenal adenoma by ACTH from the placenta, and that's how these conditions do blown up during the course of pregnancy, so labeling as a pregnancy associated Cushing syndrome. In this Cushing syndrome, a very important diagnostic modalities that helps us is the dexamethasone separation test. So let's understand the basics behind it and then we move ahead. So in dexamethasone, there are the low dose dexamethasone and high dose dexamethasone. Low dose where we are using 0.5 and the high dose they are using the 2 milligram. So in low dose dexamethasone, if there is a low cortisol is been noted, that will be considered as a normal one. But if there is a high cortisol, it is a diagnostic of Cushing syndrome. In high dose dexamethasone test, if there is a low cortisol, then it itself says that it is a Cushing's disease. And in high cortisol condition, then we need to see about the ACTH, if it is a low ACTH level or high ACTH level. If it is a low ACTH level, it is an adrenal Cushing, and if it is a high ACTH level, it itself says that it is an ectopic ACTH secretion. So talking about the diagnosis, the clinical features, as we know that there is a proximal myopathy, easy bruising, the osteopenia or osteoporosis, which induces the fractures and hirsutism from the increased androgen, early onset of hypertension in the pregnancy, and presence of red and purple stria instead of the pale stria, which normally happens during the pregnancy. The use of salivary cortisol at night in combination with urinary free cortisol are reliable confirmatory diagnostic tool in the course of pregnancy, and as per the trimester, the salivary cortisol threshold has been recommended. So in first trimester less than 6.9 nanomole per liter, in second trimester 7.2 nanomole per liter, and in third trimester it's less than 9.1 nanomole per liter will be considered. So the low dose where we are using 1 milligram dexamethasone suppression test may lead to the false positive result because of pregnancy induced hypercortisolism, but failure to suppress the cortisol following the high dose dexamethasone, which includes the 8 milligram, is in keeping with the diagnosis of Cushing syndromes in pregnancy. However, the usual post dexamethasone ACTH suppression in Cushing syndrome, which is confirmatory of diagnosis, is often not observed in a pregnancy, probably because placental ACTH production is not suppressed by the dexamethasone, and that's the reason it carries the less value. So patient without cortisol suppression after a high dose of dexamethasone with a normal to low ACTH, which is less than 4.4 picomole per liter, are likely to have the adrenal Cushing syndrome. A patient with a cortisol suppression following the dexamethasone but with a high ACTH, that is more than 4.4 picomole, are likely to have a pituitary dependent Cushing syndrome. You can see over here, if it is less than 4.4, it is adrenal related, and if it is more than 4.4, then it is a pituitary dependent Cushing syndrome. MRI is useful imaging modalities for suspected pituitary lesion as well as the adrenal masses. But gadolinium based MRI is contraindicated in pregnancy. There is no useful guide on the use of CRH as the diagnostic tool during the pregnancy. In this course, there are certain maternal complication and fetal complication. In maternal complication, which include the gestational diabetes, gestational hypertension, preeclampsia, wound infection, heart failure, psychiatric disorders, and rarely the maternal death too. In fetal complication, do causes the miscarriages, the fetal growth retardation, preterm delivery, stillbirth, and neonatal adrenal insufficiency. So there are the modalities, the surgical treatment, medical treatment. There are the drug called as metarapone and cabergoline. So surgical treatment, which is most successful as compared to the medical, both for adrenal and pituitary dependent Cushing syndrome. Medical treatment is reasonably considered as a second line, specifically for a patient who are not fit for surgery. Metarapone, it is nothing but a steroidogenesis inhibitor and is most widely used in these days. It reduces the cortisol level by inhibiting the conversion of 11-hydroxycortisol to the cortisol. Its use increases the risk of hypertension throughout the accumulation of the mineralocorticoid precursor, and therefore the monitoring is very importantly required. Cabergoline, it can be used as an alternative to the metarapone. Talking about primary aldosteronism, that is nothing but a Conon's disease. People always get a confusion between the Cohen's disease and Addison's disease and the Cushing syndrome. So I hope the slides will be helpful for you. Aldosterone production is inappropriately high for sodium status and relatively to autonomous of the major regulatory secretion. That we know that the angiotensin 2 is one of the very important in terms of regulation. The inappropriately elevated aldosterone leads to the tissue damage, suppression of plasma renin and hypokalemia, sodium retention, hypertension, cardiovascular and renovascular diseases. The most common cause of primary aldosteronism are bilateral idiopathic hyperaldosteronism and which counts for 16 to 70% and the unilateral adrenal adenoma which is counting for 30 to 40%. Unilateral adrenal hyperplasia, familial hyperaldosteronism type 1 and the pure aldosterone producing adrenocortical carcinoma are the rarest causes been seen so far. In non-pregnant state, the primary aldosteronism was estimated to account for less than 1% of the hypertension and for 3 to 15% of all patients with the hypertension. So diagnosing of primary aldosteronism during the pregnancy should be considered as a differential in a patient who are presented with the hypertension which is associated with the hypokalemia and the resistant hypertension, especially before 20 weeks of gestation. The diagnosis of primary aldosteronism in pregnancy is based on the suppressed renin and elevated aldosterone to renin ratio. It's very important for your MRCOG part 1 to remember about this line. So how it can be managed? It is managed by means of multidisciplinary team approach, give appropriate antihypertensive medications, and at that methyl alpha methyl dopa or labetalol are the first option during the course of pregnancy. Eplerenone is a selective mineralocorticoid receptor antagonist that does not have anti-androgen activities. Laparoscopic unilateral adrenalectomy is the treatment of choice for adrenal adenoma and can be performed safely after the strict control of blood pressure. Moving ahead with a very important topic, that is congenital adrenal hyperplasia, which is a rare autosomal recessive disorder. There is a mutation of gene for enzyme mediating the biochemical steps of production of mineralocorticoids, glucocorticoids, or sex steroids from the cholesterol by the adrenal glands. There are certain signs and symptoms which vary depending upon the different forms and as per the sex of the patient. Salt wasting and leading to the dehydration and death due to the inappropriate mineralocorticoids. That is one of the very important thing that you should be noting over here. Because of the inappropriate high testosterone level or androgen level, there is an ambiguous genitalia, clytomegaly, that do have the precocious puberty as one of the important signs and symptoms, virilization in adolescence, and infertility just because of the anovulation. The most common type is associated with the deficiency of 21 hydroxylates, which is seen in 90% of the cases. In 5% of the cases, you could see that 11 beta hydroxylates and the rest deficiency are just because of 3 beta hydroxysteroid dehydrogenases. This is very important cascade in congenital adrenal hyperplasia, but believe me, for your MRCOG examination, it's not mandatory for you to understand or memorize this cascade. Let's be very smart and go ahead with the easy way to remember this enzyme deficiency and what it causes. So this is a diagram where you could see that enzyme deficiency with related to 21, 17, and 11. So in 21 enzyme deficiency, 21 hydroxylase deficiency, there is an increase in androgen level. In 17 hydroxylase deficiency, there is increase in androgen and testosterone level. There is increase in aldosterone level also in the body, and because of the aldosterone level, there is increase in the blood pressure. In 11 hydroxylase deficiency, there is increase in the blood pressure and also there is an increase in androgen level in the body. So if you remember this diagram, whenever there are one is present, that one you can consider for the arrow mark, and arrow mark will show that there is a high level. So if you remember this chart, that will be helpful for your exam, because in exam they do ask which whether the aldosterone is increasing or whether the androgen is increasing this particular enzyme deficiency. As we know that 11 has 2, 1, 1. So 11 is a number which contains double one. So double one, you can see that 2 arrow, In 17 there is only one mentioned, so it has a single arrow. In 21 there is one which is mentioned at the second position. In that second position you can see that there is increase in androgen level. So please quickly go through this chart. It will definitely going to help you for your exam to understand that whether there is which portion of the biochemical parameters getting increasing. Also, it is the diagrammatic presentation where we can come to know that the BP is increasing or not increasing. So in 21 hydroxylates, we know that the aldosterone level will not go on an increase, and that's the reason BP is not increasing. But yes, because of increase in the androgen level, in female, there is ambiguous genitalia. In male, it is normal, but later it might be converting into a precocious puberty. In 11 beta and 17 alpha hydroxylase deficiency, what happens is we know that the aldosterone level on the highest end, that's the reason the blood pressure will increase. But in 11 beta hydroxylase, there is increase in androgen level. For male it will be a normal genitalia, but for female it will be ambiguous genitalia. In 17 alpha dehydrogenase, in that context there is no increase in androgen level, so male will be ambiguous because male genitalia development will require the androgen. But in female, there will be no ambiguity and female will be perfectly normal. So these are the just theoretical types of 21 hydroxylase, 11 beta hydroxylase and 17 alpha hydroxylase and 3 beta steroid dehydrogenase, how they are clinically manifesting and what are the different types, like the classical, the non-classical. Just go through the slides for the theoretical discussion, but most of the time in the exam these two charts will be helpful for you to attempting most of the questions. So what is the treatment of congenital adrenal hyperplasia? Just supply the glucocorticoids to reduce the hyperplasia and overproduction of the androgen and mineralocorticoids. Replace the mineralocorticoids and salts. Replace the testosterone or estrogen in deficiencies and optimize the growth by delaying the puberty and delaying the bone maturation. A tumor of adrenal medulla that is called as Pheochromocytoma. It causes the release of too much adrenaline and noradrenaline. And how it clinically manifests? It manifests by means of hypertension and tachycardia, excessive sweating, headache, anxiety, panic attack, orthostatic hypotension. The diagnosis is by means of measuring the catecholamines and metanephrine levels in the blood. You can perform the CT and MRI in an order to localize the lesion. And the final treatment modalities, as it is a tumor, surgical resection of tumor will be considered. Coming to the end of session, are very important questions that we quickly have a look. I understand that the champions are good enough to answer for this question. So the first question, the infants with the congenital adrenal hyperplasia, which is the most common enzyme. Come on, champs, put your answers into the chat box. Wonderful. It's 21 hydroxylase. With regards to the synthesis of adrenal hormones, which of the following is true? I expect your answers into the chat box. And the answer is zona reticularis. With respect to the androgen production in female, which of the following is false? They are produced both by ovaries and adrenal. DHEA is mainly derived from the adrenal. 2/3 of the daily testosterone production is of adrenal origin. Androgens are mainly excreted as a 17-oxosteroid after metabolism. Androgen exerts their effect by binding to the intracellular receptors. So the correct answer goes ahead. 2/3 of the daily testosterone production is of adrenal origin. And 2/3 of the daily female testosterone production is of ovarian origin. So here the question is asking about in female, so the answer is going in favor of C. So I hope this topic of adrenal glands and the hormones will helpful for you. Wishing you all the best with lots of love. I'm Dr. Dinesh, one of the mentor of StudyMRCOG.